As I mentioned, my name is Nadia Abelhad. I'm a PGY3 from the University of Texas at Houston, and I'm here to present a challenging yet interesting case. So this is a 47-year-old African-American man. He has a history of tobacco and alcohol abuse. He states that he was awoken from sleep with a crescendo-type substernal pressure. He also endorsed nausea, vomiting, and concurrent diaphoresis. Due to the symptoms, paramedics were called to the scene and vitals were as shown. Subsequent EKG that was performed showed 2 millimeter ST segment elevations in the inferior leads, as well as V5 and V6 and ST depression in AVR. So the patient was transferred directly to the cardiac catheterization lab for emergent coronary angiography with an intent to revascularize given the EKG findings. Via right transradial approach, a 6 French AR2 diagnostic catheter was used to selectively engage the right coronary artery. As shown, the RCA is a small, non-dominant vessel with no angiographic evidence of atherosclerotic disease. However, a 6 French EBU 3.5 guide catheter was then used to engage a left coronary system, and then after advancing to the proximal ascending aorta, the radiographic contrast injection prior to the ostial left main engagement showed contrast staying within the coronary vessels. Thus, a non-selected angiogram from the left cusp was performed, which then showed a triple vessel non-flow limiting possible spontaneous coronary artery dissection of the left main, LAD, and left circ with no angiographic evidence of coronary atherosclerosis. So given the high risk of the iatrogenic propagation of the dissection, conventional intracoronary imaging modalities such as IVUS and optical coherence tomography were avoided. So here are some nice still images starting from the top left and progressing clockwise. Frame 1 illustrates the initial dissection flaps that was seen, demonstrated by the red arrows upon engagement of the left coronary system. If you direct your eyes to frame 2 and 3, it shows that, once again, despite such proximal involvement of the dissection, there's no limit in the coronary flow of the left main, the LAD, or left circ. Frame 4 once again shows the remnants of the dissection flaps. So going to the management of our patient, an intra-aortic balloon pump was placed for hemodynamic support while the patient was being evaluated for potential CABG by the integrated heart team. However, shortly thereafter, he developed recurrent refractory angina as well as novel hemodynamic instability in the context of an already augmented cardiac output. So an emergent on-pump CABG was then performed with anastomoses of the left internal mammary to the mid-LAD and saphenous vein graft to the first obtuse marginal artery. SCAD was confirmed intraoperatively. So going to the pathophysiology, how does SCAD occur? If you direct your attention to the image on the right here, the initial insult is thought to be induced by a tear in the intimal layer of the arterial wall or by the rupture of the supporting vasophysorum seen in figure A. Subsequently, a separation occurs between the intima and the media, or the media and the adventitious seen in figure B. An intramural hematoma forms and blood accumulates extraluminally, which compresses the vessel and then subsequently reduces the anterior grade blood flow seen by figure C. The subsequent sequelae of SCAD can include an MI, infarction, ventricular arrhythmias, or sudden cardiac death. So going to the risk factors, SCAD is thought to occur by a two-hit hypothesis. Postulated intrinsic risk factors for SCAD include prolonged inflammatory states, connective tissues disorders, and certain vasculitic pathologies. Of note, the Mayo Clinic has a large database involving roughly 200 patients that found iliac fibromuscular dysplasia in 50% of the femoral angiograms that they performed. If you look to the image on the right, this is our patient's CT angiogram, which overall did not reveal any aneurysmal dilatation of the aorta, renal arteries, or fibromuscular dysplasia. So the second hit comes from a precipitant event, which is usually due to environmental risk factors such as emotional distress, physical exertion, vasovagal maneuvers, cocaine, and alcohol use. In our patient, his serologic studies were overall unremarkable, but his UDS was positive for cocaine. So after the CABG, the remainder of our patient's hospital course was unremarkable. He was discharged, followed up with the cardiovascular center, and he never endorsed further subsequent symptoms. So this is a nice algorithm that depicts how to manage SCAD. There's a paucity of supportive data to serve as precedent, so there's no current standardized management. If the patient is clinically stable, does not have high-risk anatomy defined by proximal left main involvement or multivessel dissection, conservative therapy is recommended. Even within this category, medical management is controversial, and in a 2018 AHA statement, they actually recommended discontinuation of systemic anticoagulation. And the role of DAPT is also unclear because of the theoretical increased bleeding risk and the lack of evidence of benefit, so thus it overall should be discussed by case-by-case basis. The major cardiac and cardiothoracic societies do support revascularization over medical management, and there remains ongoing hemodynamic instability, similar to our patient, and that's depicted by the right of your screen. CABG is preferred over PCI with stable proximal two-vessel disease, left main involvement, and possible ongoing hemodynamic instability, which is depicted by the middle of your screen. So, to summarize, non-atherosclerotic SCAD can represent as much of 10.8% of STEMIs, and it should be considered as part of the differential with special attention given to reproductive age females with a low CAD pretest probability. While optimal management is uncertain in most SCAD patients, conservative therapy is the preferred strategy. When faced with hemodynamic instability, revascularization should be considered, and when there is high-risk anatomy as defined by left main or two-vessel involvement, CABG definitely should be discussed. So I want to thank you for your time and this interesting case opportunity, and thank you to Dr. Charitakis, Dr. Gwynn, and Dr. Murrah for this, their expertise in edits.
That's great. Thank you. Any questions, comments?
Yeah, I think that, I'm sorry I came in a little late, but just by the title, spontaneous coronary dissection in a man, it's obviously an unusual case. And I think that our clinical suspicion is always higher for SCAD in women. And having had one of these in men recently, I was struck by how clean the rest of the coronary artery is. The absence of atherosclerosis should be a sign that this is a SCAD and not a thrombus. But I noted that even in my case, at least, the IVUS wasn't necessarily that precise in defining that this was SCAD and not a focal thrombosis. And you'd like to use OCT, but you also don't want to damage the vessel more. So what do you, or what do you as a case presenter, and what do you as the other faculty think about OCT versus IVUS in this setting?
I think, your comment is spot on. I mean, the whole diagnosis of SCAD has been so much underappreciated. Many, including Jack Lissaw from Canada, have raised questions that sometimes stable coronary lesions or prolonged lesions that look to us as a stenosis are in actuality SCAD when you do intravascular imaging, particularly OCT. When she did that on a number of her patients, and now they have over 700 registry, the largest registry of SCAD patients, no question that there is a large proportion of patients who we would have thought were due to coronary disease, but in actuality on OCT showed intramural hematoma and evidence of SCAD. So number one, SCAD is very underdiagnosed. And you're absolutely right. We do need to be more vigilant with IVUS and OCT in order to make that diagnosis. But to your point, there are also registries that suggest that in SCAD, especially with distal vessels, if you start doing too much imaging, IVUS and OCT, you can propagate those dissections. So I think we have to be cautious. The middle vessels, I think, is very reasonable. But once SCAD is starting to go into the small vessel, I think I would be more on the conservative side for that.
Yeah, I think those are great points. For us personally, we generally will just start with IVUS because of that same reason. Just you need a good injection for OCT, and that, excuse me, that makes me nervous. We're fortunate to work with Jackie Saw a little bit because she comes down from Canada to Seattle. And in some of these cases, we've discussed that much like when we first started looking for cardiac sarcoid, we found it in a lot of groups of patients that we weren't traditionally looking for based off their ethnic background. But similarly, that probably there's a host of people that have a different trigger. And previously, we've blamed this on a cocaine MI and treated them and gone on and haven't really considered the diagnosis. But I'm afraid to do OCT, so I just IVUS.
Yeah, we don't really have good data on how risky OCT is in this setting. No one's going
Right.
to do it. It's just kind of risky. And so, but I was a little disappointed by my IVUS imaging, I have to say. And hopefully, the advanced HD IVUS will help bridge the gap.
The other thing that I think you touched on, and it's a good teaching point, if indeed you're dealing with SCAD, and I would encourage people, to be very vigilant looking at the angiograms, particularly when you think it's normal coronary in patients with classic angina-making enzymes. Look at the coronaries more careful at the small vessels to make sure that SCAD is not being missed. And if there is a SCAD, there's a very high proportion of vascularity and vasculopathy. Over 50% of young women may have FMD. So if you made that diagnosis right there on the table, it's reasonable, and that's what they do in Canada, to do the aorta iliac angiogram, to look at the renals, to look at the iliacs right there on the table, because you can make that diagnosis of FMD right there. And also don't forget that afterwards, if you didn't do that, you do need to scan the aorta, you do need to scan the brain, because these patients have more intracerebral aneurysm, so you need to know about that.
Thank you.
Thank you.